when we are discussing the limb salvage, especially in Malwa Epicon or the MAPICON, that is in the region of Malwa, the prevention of amputation or the management of diabetic foot, how to prevent the amputation, how to go for the limb salvage. We have been discussing a lot of epidemics, endemics, but one of the endemics which is just going under the water table, which is having very significant scenario, that is a diabetic foot. And when we just go for we will not go for the what is doing in the world, what is happening around. If we concentrate in our own belt, what is happening for the diabetic foot, what is the prevalence, how the diabetic foot infections they are going on, what is the burden of diabetic foot, number of things they are to be taken care for the diabetic foot, and the only message is how to prevent the amputation. It is a global emergency, and the IDF diabetes, it has shown that the latest figures, information and projections on the diabetes worldwide, 351 million people in the working age, 351 million people in the working age, 20 to 64 years, they are diagnosed or undiagnosed with diabetes in 2019. And this number is expected to increase to 417 million by 2030 and 486 million by 2045. If this current trend continues, 700 million adults will have diabetes by 2045. I repeat, by 2045, 700 million adults will have diabetes. The number of people with diabetes worldwide, as we are going from 1 million to another million, doubling time, that doubling time is reducing, and especially in the Southeast Asia, there has been an increase from the 2019 to 2045, that is 74% increase is going to happen from 88 million to 115 million to 153 million. This increase is highly alarming, and this is the crux of the today's talk, that how to go for the limb salvage in the diabetes, especially the diabetic foot. Our scenario, when we are discussing with the USA, with the China, we are among the top 2 nations in the world which is having the highest prevalence of diabetes all around. And when we are going for the complications or the emergencies, the direct and indirect emergencies or the complication of diabetes, we are among the top 3 countries of the world. The direct complications or the indirect complications, either it is CAD, it is CVA, peripheral neuropathies, or the diabetic foot, we are among the top 3 countries of the world. The burden of the diabetic foot, it leads from either it is the most significant cause of morbidity and mortality, it is complicated by neuropathy, ischemia and infection, and the rates are increasing, and all the time there is a rule of 25 written in the book, that among all the diabetics, the 25% of the patients, they will be having diabetic foot on one side, the 25% will be having the diabetic foot on the other side, 25% will be having amputation of one side, 25% will be having amputation of the other side, 25% of them will die during the treatment. And when we are going for the diabetic foot infection, that is how the host response and the impaired neutrophil functions, they are commonly poor in uncontrolled diabetes, and if they are properly managed, we are able to go for the well acclaimed diagnostic and therapeutic approaches, and the presence of infection at any point of the diabetic foot, it just worsens the prognosis in diabetic foot ulcer. The clinical situation can become limb or life threatening rapidly. The very simple diabetic foot, whichsoever is coming to your OPD, some things may not be written here, but the practical aspect for all the doctors sitting in the hall, every diabetic foot patient, whosoever is coming to your OPD, just request him to remove the socks and just remove the shoes. Sometimes it may be very foul smelling, sometimes we may not like the smell and the scenario, but it is our duty as a doctor that any diabetic foot patient who so is approaching to your chamber, you have to request him to remove the shoe and remove the socks, because the redness, the warmth, the swelling, the tenderness, purulent or non-purulent secretions, any discal granulation tissue, or any undermining wound edges or foul odor, it will not be visible. And sometimes we may miss what is underlying in the shoes, and sometimes you may just recognize that the 1 foot is not a foot, it is just a half foot. That 1 foot is not a foot, it is losing one toe on the one side, it is losing toes on the other side. Sometimes it may be mid-tarsal amputation and patient may be just feeling shame to show you their foot. That is the clinical scenario what we are acclaiming on the daily basis. The infections on the diabetic foot can vary from the very local purulent secretions, but sometimes they can go from the neck up to the level of the superficial, mild, moderate or severe. Sometimes they can go up to the grade 4 necrotizing fasciitis infections, and when these kind of foot infections they lead into the OPD, it is very difficult not only to save the foot, it is next to impossible to save even the patient's life also if not treated at the right time. One of the most common presentations, that is diagnosing of osteomyelitis in diabetic foot. Very simple, when you remove the socks and removes the shoe, and when the very simple test, you can observe multiple discharging sinuses, you can have a simple bone probe test, sausage-like appearance of the toe, and one of the most common thing which is often missed and very cheap in the diagnostic modality, that is simple X-ray of the foot. Sometimes patients are taking treatment from the various places. When we ask about the X-ray of the diabetic foot, it is missing, and that simple X-ray that can just change the scenario of the management, that the diabetic foot, the underlying osteomyelitis, if diagnosed early, it is highly treatable and highly salvageable. The MRE, CT and nuclear scans and the bone biopsies, they further lead like the further feathers in the cap to make a complete diagnosis. The clinical test, open the shoe, remove the socks, open the ulcer, and this simple bone probe in your OPD, in less than a minute, less than 30 seconds, you will be able to diagnose that this patient is having osteomyelitis. As I discussed before, the simple X-ray, it will just let you know to what level the foot is damaged and what are the management strategies to be planned for the osteomyelitis. The simple thing is how to approach the osteomyelitis in the diabetic foot. It can be closure of the wound, it can be endovascular treatment, the antibiotic therapy, the surgical debridement or the glycemic control. If I restrict myself to the antibiotic treatment in the osteomyelitis, most of our friends, when they are treating in the OPD or in the indoor basis, after controlling a very good glycemic control of the diabetes, that is must for the diabetic foot. But when we are going for the antibiotic treatment, some points to highlight: how to choose an antibiotic. Which antibiotics are there going to help for the diabetic foot? We go for the meropenems, but simply it can be ampicloxacin. It can be ampicillin and a combination of cloxacin. As I am an international GP in Australia, what I have seen there, they just stick to their basics for the treatment of the diabetic foot. The simple antibiotics we start on the international level for the diabetic foot, even the osteomyelitis. The interval is different, but our first choice is ampicillin and cloxacin. We add for the anaerobes the metronidazole. We add for the gram negatives and the positives the gentamicin if the patient is not renal compromised. But the last line of the slide, the duration 1 to 2 weeks for mild and 2 to 4 weeks for moderate to severe, but this duration can be extended up to 12 to 20 weeks also if the patient is binding to the treatment, and if the oral treatments they are not going to act, we can save even the diabetic foot osteomyelitis. The culture and sensitivity often missed, but obtaining a specimen for microbiology, the culture should be obtained prior to starting empiric antibiotic treatment. It should be from the deep tissue obtained by biopsy or curettage, and avoiding superficial swab specimen which may contain the multiflora. This culture will often help us when we are going for the empirical treatment of the diabetic foot in the indoor. By the time the culture report comes out, we will be more brave to treat the patient so that we are able to go for the limb salvage. The commonly used antibiotics can vary from the physician choice, but the first choice, it it can be suggested to go for the ampicillin, it can be cloxacin, it can be metronidazole, it can be gentamicin, but all the cephalosporins, they are highly effective against the diabetic foot. And if these are not working for some of the pseudomonas, we can go for the simple ciprofloxacins, levofloxacin or ofloxacin, and other line of treatment we can add macrolides, the linezolid, and the meropenems, vancomycin, clindamycin, and even the local antibiotics. Some of time they are working like wonders. How you approach your patient, that is the main categorization of your patient according to you. So what you have to choose for your patient. The MRSA regimen, how the patients are to be chosen. The patients, they usually receive vancomycin and daptomycin parentally. The one tablet which we have been using in the past, that is trimethoprim and sulfamethoxazole. Nowadays, most of the doctors, we are just hesitant in using. But the diabetic foot cellulitis, the diabetic foot osteomyelitis, these drugs, they just work as wonders even nowadays also. And a minimum 8 weeks of antibiotic treatment, either per oral or IV, and DFO cure rate with parenteral antibiotic therapies 67 to 90% in the random control trials. The cure rates are increased when antibiotic therapy is combined with surgical resection. When I say the surgical resection, don't hesitate to debride the diabetic foot. The more you debride, the bravely you debride, you are more able to save the diabetic foot and you are going for a limb salvage. The duration of the treatment, antibiotics even up to 13 weeks, the guidelines from the Infectious Disease Society of America, the 46 weeks for the residual but the viable osteomyelitis bone, and at least 3 months for non-operative cases. When we are giving antibiotics for 1 to 2 weeks, for the 3 to 4 weeks in your OPDs, in your clinical ICUs, this is the recommended guidelines, 13 weeks, and for the residual 46 weeks, these are the Infectious Disease Society of American guidelines, so that we are able to control completely the infection and the limb salvage is there. The ideal dressing, what kind of dressing you are using? As I say, first remove the shoe, remove the socks. What kind of dressing? Patient has come from home. Sometimes they just come with a cloth which is not so clean. Sometimes they have applied mustard oil. Sometimes they have applied some ointment from a local halwai. Sometimes they have applied some malam from a local halwai, and the other day or the second or third day, the wound is turning black. The ideal dressing, just try to remove the excess exudate, maintain high humidity, allow gases exchange, provide thermal insulation, protection from scanty infection, and allow removal without trauma, a dressing change, and to be free from the particulate and toxic components. When you do the X-ray, sometimes you are able to see some buttons, some steel metals, some of the stone particles, they are lying down under the diabetic foot wounds, and patient is just going for the drainage. It is not healing, the sinuses are discharging, it is very foul smelling. But when you do a simple X-ray, you are able to remove the foreign body and the wounds are showing the excellent results. These surgical recommendations, just to resect the affected bone and avoid leaving residual disease, go for the debridement, brave debridement, and just when 1 digit debridement is acceptable, restrict yourself. But if you feel that in the coming time all the digits are going, just extend yourself to the middle phalanx, proximal phalanx, so that patient is able to walk on the heel. If the patient is not able to walk on the heel, they will just be lame after a few months and they will be sitting on the bed. Our aim is to go for prevention of amputation for the limb salvage, so that they are able to finish their daily life course up to a certain age group. The osteomyelitis in the diabetic foot is one of the gravest complications, and with the help of the elite class of physicians sitting here, we can prevent these osteomyelitis diabetic foot amputations in every clinical OPD. As I have said, the brave debridements, the surgical debridement, the revascularization. Some of the diabetic foot patients, they can present with the PAD, the peripheral artery diseases. They are often mistaken. We are just going for whether nowadays in some of the civil hospitals also, we are getting the CT angios done. The color Doppler is not so costly, so that we are able to right time diagnose what kind of limb is obstructed, what vessel is not working, so that what kind of infection is there, whether it is superficial or whether it is DVT. We are able to revascularize the limb. In our institute, in AIIMS Bathinda, in CMC Ludhiana, in DMC Ludhiana, we are getting number of people of high clinical acumen who are going for the revascularization of the diabetic foot, and the limbs are able to be salvaged. The wound closure, multiple techniques, whatever suits you, you can go. The stitches are to be excellently avoided to first go, but if you feel that the secondary closure can be done, that can be done with the secondary closure of the wound by the stitching. But the secondary granulation is one of the best methods to go for the diabetic foot limb salvage. The wound closure, you can go for the grafts, you can go for the multiple dressing, you can go for the VAC, and in the end, this term I hate, amputation, because this is one of those terms in which if you go for the amputation, you go for the modified amputation, you go for the below knee, you go for the above knee, your patient is ultimately going to suffer and going to lose his or her life. We have to avoid these kind of amputation with the help of the limb salvage. Just recognize the patient is having bulle, ecchymosis, fever, chills, or hemodynamic instability, tachycardia, acidosis, getting worse. The clinical judgment can be taken within 1 second that patient is getting better or getting worse. Just diagnose and treat those infections. The bad signs of prognosis, necrotizing fasciitis, the gas under the limbs, and the diabetic foot examination. Simple examination, just when you open the foot, you will be able to go for whether you are able to prevent significant ischemia or not. And taking history, just spend 30 seconds with your patient, how he or she has entered your OPD chamber, what kind of treatment, desi treatment, steroid, what kind of another pathis treatment they are taking at home, what are the comorbidities, and you will be helping the patient. The visual inspection works like wonders. Your 3 fingers on the feet, on the medial malleolus and below, and the palpation of DPA, just medial and lateral to the hallux valgus, you can palpate whether the artery is working or not. This is one of my favorite topics, footwear. What kind of shoe your patient is wearing? Is it Punjabi Jutti? Is it Jalsa? Is it Hawaii Chappal? Some of them are very dangerous, but some of them can be even working as offloading shoes. Each shoe can work as offloading shoe depending on where the wound is. But discuss your patients for the Punjabi Jutti and Jalsa and the shoes which are having very thin soles. Just say wear sport shoes which are having good soles. They are not very costly and you will be able to limb salvage. The inspection of the feet by the patient and the relative at home. The foot presentations to you in your OPD chambers. And the ulcer examination by you in your OPD chamber. The neurological examination, the simple test, and the MAT test, whichever hospitals are having, you can diagnose what level of biothiometry podia scan is showing the level of neuropathy. Vascular assessment, first your fingers will tell, then the handheld Doppler, or then the ankle brachial index. This laboratory investigation, the first go, and the treatment will be decided according to that. Categorize the patient, refer to the institute if you feel you're not comfortable and you're not confident, and just go for again and again each go examination of the foot. Recognize the early warning signs and tips on foot care with the people with diabetes. Inspect both feet daily. Ask the attendant to inspect the feet. Wash the feet daily at room temperature. Look for the web spaces. Apply lubricating oils. Cut nails straight. Don't go for the deep nail cutting. Don't remove corns and calluses as yourself, and there should be not excision at home. Always wear socks with shoes, avoid walking barefoot, and especially in Gurdwara and Mandirs in the months of June, July, August, September when the floor is very hot, just don't go barefoot so that when you come back we see potato. The foot is going as a foot, but when the patient comes back it is a potato. जिस तरह उबलिया होया आलू होंदा है, patient उस तरह वापस आंदा आपदा पैर लेके, and we are not able to simply save that foot. The patient had to spend a lot of effort, and even the doctor has to do lot of things to save those feet. These are the various footwear you can suggest your patients. Even WAC dressings are available. The hyperbaric oxygen is available in Punjab, and at the same time you can go for the foot care recommendations. I repeat that each limb salvage is to go for saving a life. Your simple Hawaii chappal in the dorsum of the foot, your simple Punjabi Jutti in Punjabi deep ulcer, it can damage your foot. But if you are going for simple sport shoes, wearing cotton socks, you can simply salvage a limb. Our aim, I highly thank Dr. Vitull Gupta for calling me to have this presentation here among all of you, my dear friends. The only aim to be here is how we can limb salvage in the diabetic foot and how we can prevent the further future amputations. Thank you so much.
Thank you very much, Dr. Sodhi, for an excellent talk. Since you are doing yourself the same things, so that qualifies you above all the academicians. So some people, they only study and do, but you are practically doing the same thing, and you are an experienced person, and you have stressed on history, examination, coming on to diagnosis in a good pursuit to salvage the limb. So we need to protect the limb. Whatever method you have enumerated, it is great. Thank you very much for apprising us about salvaging the limb rather than cutting the limb or amputating the limb. Thank you very much.
Thank you so much.
Thank you, sir.
ਇੱਕੋ ਮੈਸੇਜ ਲੈ ਕੇ ਜਾਣਾ ਹੈ, ਆਪਦੇ ਪੇਸ਼ੈਂਟ ਦਾ ਜੁੱਤਾ ਤੇ ਜਰਾਬ ਜ਼ਰੂਰ ਲਵਾਉਣ ਲੈਣੀ ਹੈ। ਥੈਂਕ ਯੂ ਸੋ ਮਚ।
ਅੱਜ ਕੱਲ ਜੁੱਤਾ ਤੇ ਜਰਾਬ ਕੋਈ ਨਹੀਂ ਲਵਾਉਂਦਾ, ਕੱਪੜੇ ਜ਼ਰੂਰ ਲਵਾ ਲੈਂਦੇ ਆ ਸਾਰੇ।
Thank you, sir. It was an incredible presentation.